Yeah. What do you have, sir? Yeah. Gotcha.
Can everybody mute? Do I have access to mute?
Okay.
Who else on here is not muted? There we go. Okay. All right, for you guys on Zoom and not live, apparently the internet over here is super special. And for some reason it sent the non-finished version of the PowerPoint. So we're gonna show the non-finished and I will try to go back and forth and get all the info in there anyways. Okay, so we need to. And then. Okay. It's not over here. This is over here. Ooh, it's gonna confuse me, y'all. I'm an old lady. All right, so we are here to do integumentary and musculoskeletal. I am Jenny Fiegel. I am a nurse on the burn unit. I have been here at Grady on the burn unit for the 11 years in July. I took my CCRN in 2015. Had kept my notebook with my notes and I went back and got it. And these two were not separate sections back then. There was a whole part on shock that it doesn't look like it's quite as separated out now on the test like layout. But anyhow, it's interesting to show of like, know the way the heart and the kidneys work doesn't change. We know a lot about that kind of stuff, but like where we've come and some of the concepts that are covered in here and like what the critical care nurse does to better patient care under these two things. So I thought that was cool. Nerdy, but cool. Okay, so per the testing plan, the things you can be tested on for integumentary are cellulitis, IV infiltration, neck fasc, pressure injury, types of wounds, and then we need to be able to recognize the indications for and manage those requiring therapeutic intervention, surgery, wound vacs, all of the things we do to prevent pressure injuries, Fecal management devices, and then what to do if an IV has infiltrated. Okay, so cellulitis, pretty basic, right? Infection of the soft tissue. I'm supposed to stand over here. Barbara said that. I'm not one to stand in the same spot. So redness and swelling of the skin, it's going to be warm to touch. The patient is going to spike a fever and they're going to have to be admitted for this because they're going to need to be treated with IV antibiotics. Oopsie, this is all over here. Okay, so IV infiltration is the accidental infusion of medications into the surrounding tissues when it was intended for the vascular system, right? It's supposed to be in a vein, did not end up in a vein. The infusion may or may not be a vesicant. If it occurs, we obviously want to stop the infusion immediately, just like we would a blood reaction, right? You want to elevate that extremity and place warm or cold compress, depending on what the agent was. So some of those agents that have antidotes require cold compresses, but that's something you'd be able to read. And like if this happens, you're going to consult your pharmacist and look up, whatever microbetics, whatever you're using at the time, your drug library. So we want to elevate that and either get most likely warm, but could be cold compress on it, and then figure out if there is something antidote for it that we need to be giving. And then if you can, move that IV site to the other extremity. Okay. All right, so there is an infiltration scale, so determining how bad the IV infiltration is. So one is no symptoms. Just locally, you've noticed that it's happened. That's 0, sorry. 1 is blanched skin, or if there's edema less than 1 inch anywhere around the site. 2 is blanched skin and edema greater than 1 inch, okay? 3 is blanched and translucent skin, and the edema is greater than 6 inches in any direction, and possible numbness in the affected extremity, okay? 4 is when it's blanched, translucent, it's tight, it's leaking fluid, you got pitting edema, it's rough. The patient is having moderate to severe pain. And if it was a blood product or a known irritant or vesicant, it gets upgraded to a 4 automatically, right? So if you have levo that we know is a vesicant and that extravasates, it's a big word, into the tissues, then that's going to automatically be a 4, whether it's swelling, whether it's red, all of those things, okay? All right, so what we're going to do for extravasation, so that's when an infiltrate of a known vesicant happens. It can cause irreversible tissue injury and necrosis, right? So it can get to the point where the tissues are dying. Think they're here for us? Hold on, guys, we got some people at the door. We had internet issues. Setup was fine. Yeah. Okay. All right. Yeah, we're currently going off of the latest version that was in my email, but the most updated version we couldn't get sent. Just me, but technology. A computer will not connect to the internet over here. I even walked back to the building multiple times to try to get on the Grady internet. Yeah. So anyhow, okay. So when we've had a known vesicant get into the tissues, it can cause irreversible tissue injury and necrosis, right? Some are so bad that you're going to need to have surgical intervention for them. And of course, like I said, this is when you want to consult your pharmacist or your drug library for which vesicants are on formulary, what we've got, and then if we have an antidote for them. Okay, so there were 2, and I actually saw them in some of the study questions, so we'll talk about those antidote examples. So hyaluronidase, yep, is used for non-cytotoxic agents like amiodarone, calcium gluconate, and mannitol. Okay, it can also be used for known cytotoxic agents like tinipicide. Right. And then we've got those that are used for vasopressors like levo and dopamine. Okay. Okay, I think we're caught back up. Okay. All right. Disease process that is near and dear to my heart. As you work at a hospital with a very large burn center, we see a lot of neck fasc. Okay, so neck fasc is a mix of bacteria in an immunocompromised patient or bacteria that's gotten into a healthy patient with a recent history of skin injury, okay? So again, I'm probably gonna tell you more than you ever wanna know about neck fasc. It, of course, has a lot of factors of how people are more susceptible to it. You know, those in the immunocompromised that have diabetes, any kind of autoimmune disorder, morbid obesity is the big one that we see a lot. But then also you have your, like I've got some pictures on the next slide. This is a woman that is young and fell intoxicated and got a skin injury that resulted in neck fasc of her right leg. So she came to us from an outside hospital. So this picture was taken on the first day of surgical debridement. So you can see like she fell, small injury, the bacteria got into her leg to the point to cause neck fasc. And you see all that dead tissue? It's supposed to be sitting in here. Okay, so that's what it looked like first surgical debridement. The only treatment for neck fasc is surgery and good wound care. Most patients are going to progress to septic shock in or MODS. Biggest things are giving them antibiotics once you've got the cultures back as to exactly what organism has caused this. Good nutrition, and then usually if it is actually neck fasc, the limb's going to be lost, as you can see here. So first surgical debridement, that's what her stump looked like at 45 days out, and then on the right there at 90 days. All right, so signs and symptoms of neck fasc, they're going to have intense pain over the involved area. It's going to spread to the surrounding skin. It's going to turn deep purple or necrotic, like you can see on her leg there. Okay. All right, pressure injury. So when it comes to pressure injury, of course, prevention is key. The #1 way to prevent pressure injury is to assess your patient. You have to be looking at all those butts and bony prominences to know what's going on there, right? Okay. All right, so we want to make sure we're using a validated risk assessment. Here we use Braden. I know there are other ones out there, so just that it is validated to accurately assess the risk of pressure injury. And then if risk is assessed, we want to make sure that we are following measures to prevent. Okay, so just a little definition from our policy. So pressure injury is localized damage to skin and underlying soft tissue, usually over those bony prominences, or it can be related to medical devices. We'll talk about that too. The injury can present as intact skin or all the way up to an open ulcer and can be painful. The injury occurs as a result of intense or prolonged pressure with the combination of shear, right? So the tolerance of the soft tissue for pressure and shear may also be affected by all of these other things going around, okay? So friction is the act of two surfaces rubbing against each other, and shear is the friction plus the gravity causing that muscle to slide across bone and obstructing the blood flow, okay? All right, so the points of pressure that we worry about in our patients who are critical and not up and moving and walking around the room all day. So the back of the head, ears, scapula, elbows, sacrum, those hips for those little bitty skinny people. And then depending on what kind of injury you've got going on, obviously the heels in a fully intact patient, but then if you've got a patient that has had an amputation, their risk for their points of pressure could be different, okay? Just got to think about what's going on. All right, so our intrinsic factors that are going to affect our risk for pressure injury: immobility, sensory loss, age, disease, our body type and habitus, if we are having poor nutrition, and then if we've got an infection, right? So then the things that we can impact as the nurse are excessive pressure, that friction and shear, an impact injury, excessive heat, moisture, posture, so how we're positioning our patients right, and then incontinence. Like that's up to us to make sure that we keep the patient free from pressure injury with those things happening. Okay. All right, so we must reposition the patient frequently to prevent pressure injury, right? So minimally every 2 hours while they're in bed, keeping arms and legs in neutral positions on pillows, assessing that risk of where all those bony prominences are, making sure we're keeping our head of bed at least 30 and only higher if medically necessary. If you've got it up too high and somebody that's not making position changes enough, right, then they're going to have greater injury or greater risk for injury on their sacrum. Okay. Okay, so in these days, we have all these fancy surfaces for our patients to sit on, right? Those beds up there cost more than most of our cars, even if you drive a really fancy new nice car. All right, so alternating pressure, that mattress is made up of many air cells, which alternate being inflated and deflated. So this redistributes the pressure and keeps off higher risk pressure points. Low air loss is where the mattress surface is covered with tiny holes, which blow air onto the patient. This helps regulate the microclimate at the skin and prevents that maceration if the patient is like staying moist. So that's who that's good for. Auto immersion, this mattress uses sensors to monitor and adjust the pressure settings based on the patient's weight and position in real time. That allows the mattress to conform to the patient's body, so reducing that pressure and optimizing bed flow. So that's our agility mattress. If you guys have seen those, that's what that does. All right, device-related breakdown. So in the ICU, do our patients have lots of tubes and lines and things that we've connected to them that are laying on them, under them, around them, all those things. So they are all points for risk of injury. So NG-OG, we want to bridle if available. This is clearly from my slides, tape if not burned. And then using some kind of tie as our last resort, and making sure if we're knotting anything that we're doing, that it's in front of the patient's face, so there's no pressure on it. All right, oxygen, ensure there's no pressure from the nasal cannula. You know, we see things that happen back here behind the ears, sometimes on the face if they're laying, or breakdown in the nose if we've got more than one thing stuck in their nose, right? If they've got on a face mask, or if they've got a trach and they're like this all the time, then their chin can break down. So we want to make sure we're using all our available things to keep their head in a neutral position. ET tubes, making sure that us and respiratory are working together to move that tube position often so that it's not stuck on the left side and then they've lost half their left lip due to pressure. Foley, so making sure we are using some kind of, now that's brand in here, but securing device appropriately so that it is not causing pressure anywhere on the skin. So it's not between the legs where you're getting breakdown, because I've seen those before. Okay. All right. So when it comes to staging our hospital-acquired pressure injuries, so stage 1 is intact with non-blanchable redness. Okay. Stage 2, you've got exposed dermis. So we've got a break in the skin now. So partial thickness skin loss. It can be a blister if it hasn't opened yet. And the bed of it's going to be pink or red. Stage 3 is a full thickness skin loss. You're going to see subQ fat visible. Stage 4 is going to be full thickness with exposed fascia, bone, tendon, or ligaments, depending on where the injury is. And then unstageable is our one that we're not going to be able to tell because it's going to have slough or eschar on top of it. So that is going to have to be debrided either with an enzymatic debriding agent, or they'll go to the OR to have it debrided, and then we can see the extent of the damage. And then when it comes to pressure injury treatment, I'm sure in the CCRN world, we're going to, contact our wound care and do whatever they say dressing wise. And some are bad enough that they will need surgical debridement and grafting. Okay. All right. Okay. Fecal management systems. So they are great when they work, but do they have their risks? Yes, they do. Okay. So we, this is pretty much our policy around them. So the FMS is going to be good for a situation where a patient is having liquid stool a lot for an extended period of time, right? So one episode of liquid diarrhea does not constitute needing a big balloon up your booty to collect all your stool, right? That's not good care. Okay. All right. So this is why we usually are told to attempt an external device before you go internal. So like using a rectal pouch and seeing if that works before you move to the FMS. Now, obviously, depending on the patient's situation, the rectal pouch may not be an option. So if they've got already have breakdown on their bottom, or if there's some kind of infection, tissue injury down there, the rectal pouch may not be an option. Or if they're burned, not an option. Okay, so things that we want to check for first is that it's not C. diff, right? Checking that they're not on a slew of medications that have the side effect of diarrhea. If that's something we are intentionally doing to them that doesn't need to be happening, then we need to reverse that. Making sure that dietary is consulted for looking at our nutrition and seeing what would be causing these liquid stools. Now, in our world, if you've got a very sick ICU patient and they're being tube fed, then yes, they're going to have liquid stools, right? So that's where this comes into play and is good for the patient. Okay, so you want to make sure that once you've placed one, that there is liquid stool coming through it, that you're irrigating it, making sure it's running, that it's not being left in for large amounts of times, because it does have those side effects of it can cause ulcers, it can cause tears. If they have them for long periods of time, they'll lose their tone completely. Okay. And then we want to look for contraindications to using them. So we don't use them in pediatrics. We don't use them in someone that's had a bowel surgery recently, or if they have a rectal or anal injury. If there's occlusion, complications, or if they are have a tendency to bleed with whatever is going on with their disease process. And then allergies, of course, allergies to everything. Okay, so we're going to pull one out if they are unable to maintain that rectal pouch or have contraindications, like I said. And then we want to make sure that we are assessing how much water is in that balloon that helps it hold in place, because that is where we see if it's leaking and somebody just puts more water in it, that's where injuries are occurring for the patient. All right. So then we get to wounds. All right, so vacuum assisted closure, so wound vacs, is negative pressure wound therapy. So the way it works is most often it's going to be placed in the OR. We see them on our floor just because there's so much use of them being placed bedside. And then of course, if a complication happens with it, you might be taking it down and redoing it at the bedside. So after cleansing the wound, we cut the foam into shapes that fit the wound. We cover the foam with a transparent film dressing. Then we put the little lily pad to it, connect it to suction. Your settings should be ordered for what kind of suction they want, but default settings are usually between -75 and -125. So the way the wound vac works is that it promotes healing of the wound bed by using that negative pressure to bring blood flow to the wound bed, okay? So things we need to be looking for on a patient with a wound vac. So is it connected? Is it set at the right pressure? Is it alarming because there's a leak? So is it something that we need to fix, that it needs to be covered? Or if it needs to be, we got to call the physician, because if it's not in the negative pressure, then that wound is just sitting in itself with all of the things that that pad had been sucking up into the canister, okay? Okay. Musculoskeletal. All right, so we're gonna talk about compartment syndrome, fractures, I made it in here, functional issues like immobility, falls, gait disorders, osteomyelitis, and rhabdo. So what they want you to know is how to manage patients requiring progressive mobility, recognize the indications for, and manage patients requiring compartment syndrome monitoring. Okay, so compartment syndrome, the causes are fractures, soft tissue or vascular trauma, crush injuries. It can happen from exercise and veneration, yeah, got words today, more coffee. Tight cast or circumferential dressings. So something we've done to the patient, pneumatic anti-shock garments, automatic blood pressure devices, massive fluid resuscitation, snake bites, and burns. Okay, so big long list of things that can cause this. The measurement can be done with, they make one-time devices and they make continuous devices that are continuously monitoring what the pressure is in this specific compartment. Okay. So I teach the 6 Ps. I did see it in a different book that there were 5 Ps or 8 Ps. And then when I was in school, we had 5 Ps. So I recently had someone teach me the bottom one. Do y'all know what that is? Yeah, so it takes on the temperature of the environment that it's in, right? So you kind of become like an amphibian. Okay, all right. So when we've got a extremity that we're watching for compartment syndrome or worried that we have compartment syndrome in it, we are looking for these things. Now, if it's a patient that is awake and alert, you need to explain these to them, okay? So you need to explain, you know, I give the example of, I remember once upon a time, I had a patient in the unit that had circumferential burns to both arms. Right arm was deeper than the left arm. So as I'm admitting him and getting all the things, I'm explaining to him, how does it feel? I need you to note the pain in both arms. Are they different? Do you feel tingling? Is the tingling different? If the tingling gets worse, I need you to let me know. Okay, so we were able to explain that to someone that's awake and alert, but if they're intubated and sedated, then you're the one assessing it, right? They're not able to tell you those things. So you're keeping track of, can I palpate the pulse? Do I already have to get a Doppler to check the pulse? What color is the extremity? You know, paralysis, you're not gonna be able to tell if they're sedated. Okay, so educating them, assessing frequently and often. And then if we're worried about compartment syndrome, we want to make sure that we are keeping the extremity at the level of the heart and not elevated to optimize the blood flow to those tissues. Okay, and then if we do have compartment syndrome, most likely they're going to end up getting a fasciotomy, right, where they're going to cut into the limb to release that pressure. Special. Okay, so things that we need to think about when it comes to critical care for fractures. So doing thorough neurovascular assessments of the affected extremity, right? So depending on your orders or the severity of the injury, that could be Q1, Q4, Q shift. If it's a penetrating fracture, you know, then we're looking at all those other risks for infections, blood clots, PEs, things that they can throw that happen with those injuries. assessing any kind of brace or cast that's on the patient so that we're making sure that we're not causing undue problems on top of the fracture they already have. If they're in traction, of course, assessing that that's all done appropriately, your weights are appropriately, that the limb is where it needs to be, that you've got all the help you need when you're repositioning them. And then if they've got pins, making sure that you are doing all your assessments for infection, keeping them clean per their wound care orders. Okay. Functional issues. So we're talking about immobility and falls mostly. And when it comes to falls, we want to make sure that we're using a validated assessment to determine our risk, and then implementing validated and our hospital approved interventions for those that are deemed at risk. Okay, so immobility. So this comes from the Society of Critical Care Medicine and all the work they have done on pain, agitation, and delirium over the years. And the last update for how old or young y'all are also included immobility and sleep. So once upon a time it was PAD. Barbara brought PAD to us. It's now PADIS. So the I is immobility. So rehabilitation and mobilization. Critically ill ICU patients, we've done all this research and know how important it is to get these people up and moving as soon as possible and all of the things that come with doing that. So improving their muscle strength when they get to go home, reducing the duration of them being on the vent, shorter length of stay. So the less time you're in the hospital, the less time you have to acquire hospital-acquired conditions, right? Less time in the ICU, less time to get delirious. So ICU delirium is decreased by getting up and moving. And then we've seen that there can be safe initiation of it, even if the patient is critically ill, right? So there's things that we'll talk about next. And then that vasoactive infusions or being on the vent are not barriers, right? Where once upon a time you were not walking someone on a vent. And now we know that yes, you can get someone up on the vent and ECMO and walk them. Okay. Oh, okay. Oh, guys, this is fun. All right, so back to immobility. So using a mobility protocol is the best evidence-based care for our patients, okay? So the example of the recent book, the CCRM book that I was looking through, has a MOVES, which is what we use here at Grady, right? So the MOVES protocol is how we are assessing our patient. They're falling into a category, and then depending on that category, that is where we know what is safe to do with them mobility-wise, okay? So exclusion criteria, if they're on spinal precautions with or without orthotic device clearance, we're not going to get them up and move them. If they are actively bleeding or actively receiving MTP, they're probably not appropriate to get in a cardiac chair, right? If they're having an active MI, they're out of the MOVES. And then if they are suspected or confirmed difficult airway, if they're being mechanically ventilated, then they are not going to fall into a MOVES protocol, okay? So as long as those things aren't happening, we're going to run through what, there, it's not there. Is a MOVES. So with that acronym, y'all know in ICU care, there's an acronym for everything. Okay. So MOVES, M is myocardial stability. So either we've got no evidence of active MI, no acute or no new dysrhythmias. The heart rate is greater than 50 and less than 120, and their MAP is greater than 65. Okay. So as long as they meet all those criteria, check, we move on to the next one. Okay. The O is oxygenation. So their FiO2 has to be at less than 40%, right? Because someone receiving higher is not quite as stable, probably shouldn't be up and get moving. They need to be satting greater than 88%. And of course, that is going to be definitely, maybe that's probably the one that's the most patient specific, right? Because you could certainly have a COPDer that lives at like 87, at 88, that kind of thing. So they're appropriate to get up because that is their baseline. Their PEEP needs to be less than 8, pressure support less than 10, and respirations less than 30, okay? All right, so if they check the O box, then we move on to V, which is vasopressor administration, or they're like hemodynamic stability. So no more than 1 vasoactive infusion. So it's okay if you've got one running, so levo, epi, what else is on this list? Vaso, if they've got one of those going, it's okay. And then no increase in vasopressors within the last 2 hours. So if you've got someone that you are titrating that levo, every 3 to 5 minutes to get their map to stay where it needs to stay, they're not going to pass this box. Okay. All right. The E is engagement or neurological stability. So not actively seizing, not on any paralytics, right? We don't get somebody paralyzed with the cardiac chair. No ventricular drains or ICP monitoring, physician specific, dependent, right? No evidence of withdrawal or agitation. And then their RAS score needs to be at light sedation up to +1. So -2 to +1, they're appropriate to check off this box. All right, and finally the S is spinal cord stability. So if it's applicable to the patient, so they've got spinal clearance documented, there's no evidence of orthostatic hypotension and no evidence of autonomic dysreflexia. All right, so many things. I think we're back. Okay. All right, so we determined it's okay to move them. So now we're going to talk about falls. So this lovely picture up here in the right with all those red ovals is your areas in an ICU room where the patient could trip, could fall. Something connected to them is going to cause them to have a increased fall risk. Okay, so the environmental factors that we need to be thinking about in our rooms. Do we have cluttered tables, stands, chairs? Do a lot of stuff go into taking care of a critical care patient? Right, stuff. Inadequate lighting, if there's spills on the floor, or if the floor is wet, right? Your EVS person has just cleaned your room and now PT's in your room getting your patient up, not the best idea. Do we have obstruction to passageways? Are there absent, broken, loose handrails in bathrooms or hallways? The bed or stretcher brakes are not working, or the bed's not in a locked position. Wheelchair brakes not working or not in locked positions. And then we've got rolling equipment without brakes or locks, and then broken furniture are all environmental factors that we need to fix. All right, so interventions to keep our patients from falling in the ICU. So assessing their ability to get up and go. So get up and go is the other moves protocol that we use here in the hospital, more so for acute care. But again, it's that if that patient is able to get up, do you know what they need to get up safely, right? Making sure they've got their non-skid footwear on, making sure all chairs and wheelchairs have functioning brakes. Have you got them into, a cardiac chair that the wheels are broken, the strap is broken, those kind of things. Assisting them if needed. Making sure that you're assessing their need for assistance during elimination and remaining with them if needed. If they're getting up to a bedside commode, yes, they may want privacy, but if you step too far away, they might be falling off that bedside commode, which we don't want, right? All right, making sure we're keeping a night light on during the night and then during the evening night hours, providing adequate lighting during the day, maintaining high visibility, so curtains, doors, and blinds open when you're not in the room with them, reorienting the patient if they're somewhat alert, or I guess not in a negative RAS, and then communicating fall risk to all staff involved in patient care. So your shift handoff should include what you've assessed their fall risk at, making sure your techs know, and then giving good report to your transporters if they're going somewhere. All right, and then there's special populations when it comes to fall risk. So the following patients are considered high risk no matter what. All patients in critical care, any pediatric patient in the inpatient area, OB patients through the first 48 hours post-delivery, and then patients being transported for procedures and treatments. Osteomyelitis. So osteomyelitis is a bone infection caused by infection in the bloodstream, getting into the bone, or an infected wound with a bone exposed or fractured. Okay, so those at risk are those with recent surgery, injury that exposes the bone or foreign body, stepping on a nail, it's one way to get osteomyelitis, chronic long-term diseases like diabetes, HIV, rheumatoid arthritis, sickle cell, If you have renal disease to the point of requiring dialysis, those are all chronic things that can put you at more risk for this. Reduce blood flow to the area, so any kind of vascular issue. If you've got an artificial joint in your body, or if you have plate or screws that have been put into your body to repair bones or joints. Okay, so things we're looking for these patients. Are they having fever, chills? Are they having swelling over the affected extremity? The skin is red, it's warm. They may feel pain, it may feel stiff. And then you're going to see drainage of fluid and pus near the infection site. All right, so the way we're going to treat that is IV antibiotics. So they're going to need to be in the hospital for this, and then most likely we'll have some kind of PICC line placed to have probably 6 weeks or so of antibiotics at home. So think about all the education that comes from the nurse for a patient going home with intravenous access. And then of course, most likely surgery. So we're going to need to remove the tissue from the bone that is infected. And then if it happens to be hardware that is causing the infection, that hardware is going to have to come out. Okay, rhabdomyolysis. So we see this in patients that have had crush injuries, prolonged immobility, compartment syndrome, hyperthermia, and then delirium tremens is all ways that it can happen. I know I said earlier, exercise. One of the patients I cared for, I started in the intermediate care unit at St. Mary's in Athens. And I remember having a college girl that had exercised so much, not hydrated, not eaten, she had put herself into rhabdo. It was dicey and very young. Okay, so what are we looking for? The patient's going to have that dark brown, like tea colored urine. If they're putting out at all, they're definitely going to have decreased urine output. We're going to be seeing myoglobin in the urine, and they're going to have an elevated CK. They're going to have muscle cramps, and they can have arrhythmias. Okay, so our treatment is that we want to flush all that out, right? So our muscle has broken down, putting all these things into our system that don't need to be there. So we want to give normal saline to maintain a urine output at about 300 an hour. So you might be giving very large volumes to make this happen. And then maybe thinking about administering mannitol. There's some data out there for that. So that's going to help decrease the swelling in the injured muscle cells and help restore their function. So we're going to be monitoring their hyperkalemia and treating it if it's there. And then we're going to continue this fluid flush until the urine is cleared of myoglobin. And that's it. Yay. Questions that I can answer?
Are they going to ask what kind of antibiotics you need here, like that?
So you'll start with broad spectrum and then do cultures for the majority of these disease processes. I wouldn't think so. I mean, I feel like they wouldn't go any deeper than knowing that like ANSAF is like, you know, #1 for skin infections, but yeah. I mean, there are general, you know, there's a list of bacteria that cause neck fash, but I can't imagine that the exam would get that in depth, right? Yeah, Lauren, I was saying earlier that I took this 8 years ago and I pulled out my notes and these two were not sections. So I had to borrow a recent book from somebody to pull from. All right, any questions online? All good, guys? Yeah, what did I think the current one said? There might be like 2 questions on each of these. Okay.